Forum on Long-Term Care Financing, held at the McNamara Alumni Center at the University of Minnesota. Session title, A New Public-Private Partnership, Catastrophic Public and Front-End Private Long-Term Care Insurance, presented by Marc A. Cohen, Ph.D. Filmed on January 7th, 2020.
First of all, thanks to DHS, to Commerce, the University, Luray, and Aging Transformation, Own Your Future for inviting me to talk about long-term care financing. So I'm going to provide some background on the magnitude of the problem, characterize some of the current approaches associated with financing care, and present a new approach to harnessing the public and private sectors to move the financing system, and here's the key, move the financing system away from a welfare-based model toward an insurance model. And I'm going to take the time to do this because I'm going to draw out a couple of I think, key points that will help me make the case for the approach that I'm putting forward with some colleagues, Judith Fetter over at Georgetown, professor, and Melissa Fevreau at the Urban Institute. The financing challenge. It is big, and I've listed some key facts there. When you combine paid and unpaid care, you're talking about 25 million of today's seniors, 65 and over, are going to need some level of care. It's going to cost over $2.5 trillion, or $6 trillion, $2.5 trillion within the next 10 years. And this is not even taking into account the 40% of current users who are under age 40. Now, the issue here is that long-term services and supports financing this care represents a major threat to retirement security. Most people are not poor enough to immediately qualify for Medicaid, and so they're exposed to really potentially catastrophic costs. If they had to pay out of pocket, the costs exceed most of their accumulated wealth, and there's only a small percentage that could actually afford to pay for the care. So it leaves families with an ever-increasing caregiver burden because they can't pay for care, they can't afford it. So it undermines people's preparedness for retirement. That's number one. If we look at the expected lifetime costs, okay? Now, these are for people who typically have 2 or more limitations in activities of daily living. This is the criteria of need that is often used to trigger, for example, benefits under long-term care policies and even Medicaid eligibility in certain states. It's highly linked to that. What I'm showing you here in this chart, these represent the expected cost for the entire population. So it includes the 48% of people who do not actually become LTSS needy. Okay? Their out-of-pocket costs would be $72,000. Now, in that little box in the middle, what you see is the average lifetime costs for those who reach this disability threshold, okay? And they have to purchase care. For them, they can expect to spend $140,000 out of pocket. And as we all know, when we look at the average value of 401ks, even for those who have them, there's not a lot left there. Now, one of the interesting things about the long-term care risk itself, and why I want to spend a minute talking about that, is that it's highly skewed. And you can see in this chart, for example, that almost half of the people retiring at age 65 will never need long-term services and supports at a level of need of 2 or more ADL limitations, okay? But 1 in 6 will have significant need, okay? That's close to greater than 5 years of care. So here's the upshot. The upshot is it's a really difficult risk to plan for because you don't know which one of these slices you're going to be eating from when you retire. You don't know where you're going to land in that distribution. It's very difficult to predict. And so in this next slide, it won't surprise you then that the liability is also highly skewed. Some people are going to pay nothing. Other people are going to pay a lot of money. So what is our current approach? What are we doing right now to address this financial liability? So our current approaches, there are really 3 current strategies, okay? There's public approaches, they're primarily Medicaid, the largest payer of long-term service and supports. There's public education campaigns to spur action about risks and so on. There are primarily private approaches, insurance, current income. There are a small number of people who use their home and annuitize that to finance care. And then there are mixed approaches, partnership programs between states and the federal government. There are about 45 states that have such programs. There are federal and state tax incentives for long-term care insurance purchase, and there are state employee long-term care insurance programs. So these are the three broad categories of approaches to financing care. Let's walk through each one of them. So what are the challenges with Medicaid financing? Well, the first one that I think everybody is well aware of is that obtaining eligibility, if you're not already poor, means that you need to spend down a great deal of your income and assets in order to obtain eligibility. So for many people, it's viewed as a threat to their financial security. Second, in many states, there are waiting lists and access limits for home and community-based care, so you can't always get the care that you need when you want it. There tends to be restrictions on service, on certain levels of service flexibility, and to Lorraine's point about state action, states are struggling under the budgetary pressures associated with rising Medicaid LTSS costs. It's now approaching 30 to 45% of state Medicaid budgets, okay? And something that's not often talked about but is really important is that the reimbursement rates do not often support the development of a high-quality workforce and service infrastructure. I could talk for an hour, I won't, but there's some really significant problems with our workforce, and it's not helped by pressure on the state Medicaid budgets. What about private long-term care insurance? So today in the country, there are about 7 to 8 million people who have policies, and premiums for standalone policies are now out of the reach of most middle-class Americans. Okay? In Minnesota, I did some checking right before I came out. There's about 200,000 people have policies in Minnesota. Now, the problem is that over the last 2 decades, we saw a major exodus of companies from the market for a whole host of reasons. The biggest being that just the returns that insurers were getting were well below expectation for a host of reasons. And so I remember doing research at the beginning of, in 2000, there were more than 100 companies selling a meaningful number of policies. Now there may be a dozen or so that are selling any meaningful number of policies. The other issue with long-term care insurance, of course, is that it's voluntary. So that means that in order for the insurance to work, there has to be underwriting. We did some research showing that roughly 30% of the population would be screened out if normal underwriting criteria were to be applied to the population. There have been rate increases. This has really unnerved consumers, but there is a bright spot, and that bright spot is growth in combination products. And I know that right now these are the subject of a great deal of attention in the state of Minnesota. How to combine long-term care coverage with other coverages, combining it with medical insurance, Medicare Advantage, or Medigap insurance, and others will have more to say about that. But that is the one area of the market that actually is growing. And reliance on families is becoming much more difficult. Family caregivers currently provide 37 billion hours of care at an economic value of more than $470 billion, more than 6 times the amount paid by public payers. But there are some trends that are occurring that are really putting strains on this family caregiving system. The first is that the caregiver ratio is changing. Right now, within the next 20 to 30 years, for every 3 people, there will be 3 people of peak caregiving age for every 1 person who needs care, compared with 7 people right now. So that capacity in and of itself, just numerically, is shrinking. There are a whole host of other unprecedented changes related to the fact that we have smaller family sizes, there's increasing employment mobility among children, and we've often talked about the sandwich generation. Frankly, at this point, I think it's better characterized as the panini generation, being squeezed from from both ends, from elderly parents, from children that are returning home after college. Many elders, as a result, currently are living with functional or cognitive impairments with high levels of unmet need. Okay? And the number of people that are going to need care is going to grow. So you take Medicaid, private insurance, and families, and where does that leave us? It leaves us between a rock and a hard place. I mean, this is a summary from some work we did at the National Academy of Social Insurance that just basically says, you know, it's costly for people, they don't have enough money, access to Medicaid is difficult, private long-term care insurance is not really available. So what do we do? And that's what I want to spend the bulk of my time talking about. I mentioned something about the skewness of that risk. I want to return to that. What holds promise, I think, for attempts to address and tackle this issue is the fact that the distribution of the long-term care risk makes it perfectly suited for insurance. Forget about whether it's private or public. You have many people who are going to have no need or a small number they're going to have a catastrophic expense. It's difficult to know years in advance where you may fall. Okay? And even for those who have the resources, savings for a risk with that type of distribution does not make a lot of sense. It's just unreasonable to expect. It would be like me saying to you, you have a very small risk of a fire in your home. Because it's, you know, because half of you are never, or because very few of you are going to do it, why don't you save for that risk? I mean, that would be crazy to do that. You would rather pay a certain amount, premium, to address a very uncertain risk. And that's why this is so, I think there's a light on this issue. Now, what has stymied reform? I mean, what I'm going to talk about, frankly, is not all that new, but what has really stymied reform for all these years? And the fact is there's been a real philosophical conflict. Reform has been, or a real strategy has been absent because you have those who would limit public policy to the promotion of private insurance. There was a fundamental belief that the role of the government is to promote private sector solutions and to only step in should private sector solutions fail. You have those who felt that, who regard public insurance as essential because in a voluntary insurance market, by definition, it's going to leave out a lot of people. Now, what has happened over the last number of years, I would say 3 to 5 years, is you have a number of groups that have started to come together and coalesce around a concept. And that is, there was a group, the Long-Term Care Financing Collaborative in DC, Leading Age, the Bipartisan Policy Center, have all started to come together representing, you know, some, you know, further, very definitive, others not so definitive, but this idea of some kind of a public-private partnership that is based on moving our financing system away from a social safety net welfare approach toward an insurance approach. And so what I'm going to talk about today is work that I mentioned that I've been involved in with Judy Fader, professor at Georgetown, Melissa Favreau, an analyst at the Ehrman Institute who has done tremendous financial modeling. So I'm going to be able to show you what some of the impacts of this program are. And our basic concept, frankly, is quite simple. The idea is that there will be a front-end kind of private sector approach. And by private sector, I mean the following. I mean family caregiving, savings, insurance, okay, a whole host, and a back-end public insurance approach for catastrophic risks. And I'm going to tell you why I think that that's the right way to go, and why I think it's going to take us furthest. Okay, there are a couple. Let's start with the question. Well, why public insurance for the back-end risk? You know, what is unique about that? So there are a couple things. I mentioned that, at least in the United States, there's a presumption that government enters markets when there's market failure. Okay, that tends to be the presumption. This is a classic case where the private insurance market has actually failed on the catastrophic risk. What do I mean by that? You don't have insurance carriers any longer that are willing to provide policies to cover that back-end risk. They voted with their feet. They're not doing it for a host of reasons, which we can talk about later. And part of the reason is difficult to price an uncapped risk like that in the context of voluntary insurance. Even for those carriers who are providing that back-end risk, and there's only a couple of them, the premiums are so high, very few people can afford them. So what does that mean? It means that the middle class is the most exposed, okay? Now, the poor and near poor have protection through Medicaid. And notwithstanding some of the shortcomings that I mentioned about the Medicaid program, the Medicaid programs around this country are darn good. They provide a lot of critical care and good service. But when you have people who could have alternatives making claims on the social safety net, it weakens it for those people, the poor and near poor, who don't have any alternatives. Okay? And the wealthy can self-insure. Okay? So the focus here on this program is really on middle-income elders. Okay? So there's another reason why public insurance for back-end risk is so important. First of all, there are a lot of public costs associated with families trying to address these catastrophic costs. Okay? It added health care costs to family caregivers. There's a lot of research showing about the negative health impacts over a long expended time. In particular, women are having to make workforce accommodations, leave the workforce, not take promotions, and so on. And there's reduced savings for retirement, okay, which increases future demand on the social safety net. And even with a viable private insurance market, okay, not everyone would be able to afford it, and there would be an underproduction of private insurance because of unaccounted public costs that I mentioned. Okay? The other point is that public insurance on the back end would not distort the use of paid and unpaid care. The way that I'm going to discuss this is that people will need to have functional or cognitive impairments for a particular period of time before they can then access public insurance. I didn't say they will have to spend a certain amount of money, okay, in order to get it, because I don't want to devalue the important family care, okay? So the idea is that if you can promote a robust, comprehensive insurance solution that has what the private market really wants, which is front-end coverage and willing to provide products for that more limited coverage, and the public sector, which is big enough to handle that risk, we could promote a comprehensive insurance solution. So what are the key features of the policy proposal that we're putting forward? So first of all, the catastrophic event is described in terms of time one must wait after becoming, I'm saying disabled. When I say disabled, what I mean is functionally impaired or cognitively impaired and requiring human assistance to perform activities of daily living. Okay? The range of the waiting period, though, would vary between 1 and 4 years. What's the reasoning behind that? Well, what may be catastrophic for me could be very different, a very different definition for someone else. A lower middle class individual having to pay for more than 1 year of care may be very catastrophic. A very wealthy individual could afford to either purchase a product or self-fund maybe 2 to 3 years of care. So there's this idea of a sliding waiting period for the public coverage, okay? And it's the other feature of that is that the waiting period, tying the waiting period to income, makes private insurance more affordable, okay? Let's take a quick example. Suppose I'm a lower middle income individual, and I'll define those in a minute. and I know that I have to take care of my care for 1 year, and then if I have additional need after 1 year, there's a public social insurance program to take care of the rest, I could probably afford a 1-year product, okay? Suppose I'm on the more upper end, and it's a 3-year, okay? I could probably afford a 3-year of coverage policy. So it accomplishes two things. It makes private insurance more affordable, and it takes the risk that the private insurance industry is not willing to take. And the basic idea behind it is it limits the financial exposure to liabilities that middle and higher income people can reasonably be expected to manage themselves with insurance or savings. The second piece of this is revitalizing the private insurance market to overcome the poor penetration and underperformance, as was mentioned earlier. And there's a host of, in the paper, there's a host of strategies that we talk about for how to go about doing this. So here are the key parameters of the public insurance plan. Okay? I mentioned that public protection would come into play after an income-related waiting period had been met. Okay? A package of actions designed to spur the development of affordable products in the private insurance market to grow that market. The way that we conceived of it was eligibility would be phased in, and it would be an earned benefit, okay? Meaning that you would pay, the financing would be a premium surcharge on the Medicare tax. It doesn't have to be. I'll talk about why we went down that road. And we were talking about a benefit that would primarily cover home and community-based care, $110 a day cash benefit. It could be paid out weekly or daily, and it would be unlimited once an individual met their waiting period threshold. Okay? Here are some of the key parameters on the private insurance side. And Minnesota is already starting to do some of these things, thinking about using different chassis to add in private insurance, but you would want targeted public education, making the marketing, trying to reduce marketing costs of policies, reforming product pricing, potentially moving away from level-funded products toward term products, and even targeted tax benefits to make these products more affordable. And I say targeted because you want to make sure that you're targeting tax benefits to people who could not afford to purchase policies in their absence. There's no point in giving tax benefits to people who could afford to pay for policies anyway. What are some of the additional features of the policy proposal? So first of all, it encourages family care while limiting family risk. So if the waiting period is based on how long someone is ADL dependent versus how much they spend on care, okay, it avoids the financial barriers to receipt of financial public benefits, okay? And the idea is it would be a cash benefit so that people, for administrative simplicity, okay? It relies on mandatory automatic participation in tax financing. And here the idea is that this is akin to an earned benefit, okay? That people feel, just like they do with Social Security and Medicare, they're paying into something, and if they have this event, they get something out of it, okay? The reason that we're recommending putting a surcharge on Medicare is because the Medicare tax is a broader tax, okay? And it's much more progressive, unlike the Social Security tax. So it minimizes burdens. When you broaden the tax base like that, it minimizes burdens on low-wage earners. Okay? We also discuss what happens if you become functionally impaired before your retirement and so on. And you can think about shorter vesting periods before that. Okay? So I mentioned this notion of waiting periods and public coverage by quintile. This is how we conceptualized the public coverage. So you can see the lowest quintile, the lowest 20%, what average income was, okay, what the limit is, and what the waiting period would be. So for the first 2 quintiles, for 40% of the public, you're talking about a 1-year waiting period. For the third quintile, 2-year, the fourth, 3-year, and for the 5th quintile, the top 20% of Americans would have a 4-year waiting period. Now, I mentioned this notion of linking this to the affordability of private long-term care insurance. Let me take a minute and explain this graph. So you'll see these were hypothetical premiums for a 1-year, 2-year, 3-year, and 4-year policy operating in the marketplace. And on the bottom, you'll see the range of the percent of income that would need to be spent on premiums by families, okay? Now, the reason we did this, and the point I want to make here is, if you look at all of the research on who buys long-term care insurance, it turns out that the people buying the insurance are spending somewhere between 1% and 3% of their income on insurance premiums. And that holds across many different years. So our notion was, well, maybe if we could peg the public coverage to start at a point where that quintile group would only have to spend between 1% and 3% of their income, that would seem to be fairly reasonable. So that was the logic, and you can see I have it in red for each of the quintiles. What percent of their income they would have to spend on a private policy in the context of public coverage that was, 2, 3, or 4 years waiting periods. Okay, everyone follow me on that? Okay, good. What I was trying to demonstrate was, if you focus on what's in red, okay, what that shows, let's take that lowest, that a 1-year policy for a 50-year-old, okay, that was modeled here, was about $541, okay, when you look on top, okay? And if you look down below, it shows that for the second quintile, okay, that would represent between 2% and 3% of their income. If you go to like a 2-year policy, okay, at age 50, that premium is $1,082. That, for the third quintile, that represents, again, in that range, between 2% and 4%. So the idea was, can you also set a public waiting period so that private insurance premiums would be affordable? And how do we know what's affordable? We look at what we see people currently spending and make a judgment that on average, people will spend between 1% and 3%. Now, what you could say to me is, look, that lowest quintile is going to have to spend somewhere between 3% and 10%. And you'd be right. They're going to be much less able, even if they only have to cover a single year of significant need, much less able to afford it. Hence, the combination of some private insurance, family caregiving, with the knowledge of the caregiver that there's, help is on the way. They've got, in a year, they will qualify for the benefit. So let's look at who gets the benefit. Now, what we've done here, you could rightly criticize this by saying a sliding waiting period, that might be complicated for people to plan for. And so what if you just made it simple and said, you know what, there's a public insurance program, it kicks in after 2 years, or 2.2 years. And so what we did is we modeled both a variable waiting period, which you see there, it says income related, and a fixed waiting period. What it shows, basically, is that the proportion of covered individuals is pretty much the same. Now, who gets the benefits is different, but you're talking about roughly 1 in 3 people will receive public benefits under this scenario. okay? And the percentage of the cost that'll be covered would be 30%. Now here's where, in this next slide, you can see how they really distribute, both of them. Let's just focus on the income-related waiting period, okay? Here you can see that as your disability period gets longer, okay, a higher percentage of people, of course, are covered by the program. It starts out at 20%, then 40, 60. If you're in that catastrophic slice I pointed out earlier, 5 or more years, you know, all of you are, almost everybody's getting benefits, okay? And you can see with a fixed waiting period, for example, 1 to 2 years of care, nobody's getting benefits. So you see a little bit different distribution, okay? The program reaches more than 40% of the population in each of the lowest 4 deciles of the income distribution, okay? It's about 7 to 10 percentage points higher than the percentage reached by a program that has a flat waiting period. Okay? Now, because the flat waiting period approach applies a shorter waiting period for people with higher incomes, of course, a far larger proportion of those individuals would get benefits under such an approach. And there may be political reasons why that might be more attractive. What does this do to this system? So this is actually, to me, this is one of the more important slides, because obviously it is shifting monies around, right? There are people who would have gotten no paid care, people who would have gotten Medicaid, people who are living with unmet need, and so on. And so what this slide shows us is that, first of all, there's a very large impact on Medicaid. There would be a 23% reduction in Medicaid expenses, okay? And think about, you know, who Medicaid ends up paying for, okay? People who really are skewed toward long stayers and so on. So you'd be replacing a lot of Medicaid dollars, which means obviously you'd be reducing significant burdens on the Medicaid program, number one. Number two, you would reduce family out-of-pocket spending, okay? And there would be more money injected into the system, which is something that is, anyone who deals with the workforce understands the importance of that. You would have a 15% increase in the total resources going into the system, which would lead to lower levels of unmet need, which, by the way, there are high levels of unmet need reported out there. Okay? So family caregivers would benefit along with beneficiaries from new services, as they're likely to somewhat lessen the burden of hands-on caregiving in the presence of such a program. So, in summary on these benefits, it injects significant new dollars into the system, okay? The income-based waiting period design reaches more low and modest income families, those who traditionally don't have private insurance options, and it allocates more spending to them compared to the fixed waiting period, okay? Now, none of these estimates that I put forward take into account the potential effect of an improved and significant private long-term care insurance market, okay? We couldn't model that. But the idea here is that a vibrant market is critical to assure that middle-income people have a way to plan for this liability. And for once, there would be a clear delineation. One of the challenges is that it's very difficult to know when the public sector begins, when the private sector leaves off, who's responsible for what. It's very confusing. If you have a very well-defined proscribed program, at least people have a shot at knowing what they have to plan for. So what does something like this cost? right? That's a critical piece of that. So in this slide, what I've shown is currently what the current Medicare tax is, okay? The program, the additional tax rate for this program is 1 percentage point of earned income split between employers and employees. And this is the level of tax designed to assure fiscal solvency over a 75-year period. The idea of the program is that it is self-funded, okay? So the actual premium charge to an employee is about $486 per year or $41 per month based on total cover wages in 2015. In this case, if you split it between employers and employees, so for example, in Washington State, it's funded just by employees, but if you could, they could have chosen, or another state could choose, to split it between employees and employers, you're talking about $21 a month. I always like to say, well, is that a big number? Is it a small number? It's hard to sometimes get a handle on that. I mean, whenever you talk about taxes, people think of it as a big number. Then I went and I started just looking at comparable costs. So what do we typically spend? We all typically spend at least $35 a month on internet, $148 a month on cell phone costs. This was astounding to me. I'm not a restaurant person, apparently, but average Americans spend $190 on restaurants over the course with their families a month. So this puts it in a little bit of perspective. There's a lot of education that has to go on, but somewhere between $21 and $41 a month, starting at age 40. By the way, we began at age 40 because we didn't feel that it was because of competing demands on people's resources at those young ages. We wanted to try and push off as long as possible when they would have to start paying in. So here are some questions about this. Number one, does the complexity of an income-based waiting period warrant the administration and marketing complexity? I pointed out what the advantages are, right? It really targets to people who need it the most, but it might be difficult, it might be administratively difficult. There's the political challenge of a mandatory program with income-conditioned benefits and a highly progressive financing mechanism, right? Medicare tax is highly progressive. As part of the ACA, it covers a certain amount of assets, high wage earners' assets and so on. So it's highly progressive, okay? But you could treat the proposed surcharge more as a premium than a tax. You could allow people to opt out, if you were really concerned about the mandatory nature of this. If you wanted to limit adverse selection, you could give people an ability to opt out at certain points in time. And to encourage early participation, if you wanted to try to do this on an opt-out basis, you might have that tax increasing for people near retirement. There's a whole host of transition issues, the biggest one being that if this is totally self-funded, it means that the baby boomers who are starting to retire will not benefit from such a program, right? So now Washington State has, is going to be starting the implementation of their program, I think, in 2023. You'll hear more about that. So they understood that there was a period of accumulation. But that doesn't mean that a state couldn't decide to allocate general funds for transition benefits. And that's probably what you would need to do to garner the necessary political support. To sum up, or to wrap up fairly quickly now, like what's happening in the country right now? And at the federal level, there's a number of bills that are being put forward that federal bills, Pallone, Sanders, that are trying to link some type of coverage for primarily home and community-based care to the Medicare chassis. Not likely that much is going to come of that for a host of reasons. So as Lorraine said, there's growing interest in state initiatives. And why are states so interested in this? Well, they're left holding the bag. And that's why we're seeing Hawaii, Washington, Minnesota, Maine, Illinois, Michigan, a whole host of states are starting to explore what they can do. Because, frankly, at the end of the day, the costs of waiting are starting to exceed the costs of doing something. And, you know, policy change never happens unless there's a demand for it. And that's why we're starting to see we're starting to see it start up around the country. You know, one question is, do states have the expertise to do programs like this? And the answer is yes, actually. States are most familiar with the local long-term service and support delivery system. They're the primary administrators of the Medicaid program. They understand benefit eligibility, administration. They have experience with other social programs, paid family leave. There's already an infrastructure in a lot of states that could be built on, that states could take advantage of. And there may be greater political flexibility and feasibility because you can link it to the unique needs in the political environment. So how do you overcome the political challenge of a reform like this, or any reform? First, at least in my view, and I've been at this for a long time. I've been at this for a very long time. And it's so clear to me that the magnitude of this problem means that neither the public alone nor the private alone can or should address this problem. The nature of this care is it's personal. There's substitution issues with family for paid care and so on. What's needed is a mixed approach where sectoral roles are well defined and enable citizens to plan appropriately. The age wave, it's cresting, you know. So now is the time to experiment with new models and build on the infrastructure and knowledge that you've been acquiring all these years. And there are proof points. That's the other beautiful thing. There are proof points to look at. There's also an opportunity for building coalitions that you might not have thought about. First, as baby boomers become caregivers and care recipients, they're going to demand improved access to affordable care. Allies will include the children, younger people with disabilities, who regard independent living support as a civil right. And it also includes the caregiving workforce. Again, policy change doesn't happen unless there's a demand for it. To what end? Why do all this? These are really, in my mind, as what has to be your North Star. You know, whatever approach a state takes, it has to be with the goal of improving access to the system, reducing family out-of-pocket spending, reducing Medicaid spending, assuring fiscal sustainability, and political support and sustainability. So, my last slide, one of my favorite quotes. Am I swinging at windmills? I don't think so. Is this just wishful thinking? This is a quote by Milton Friedman, the conservative economist from the University of Chicago. Only a crisis, actual or perceived, produces real change. When that crisis occurs, the actions that are taken depend on the ideas that are lying around. That, I believe, is our basic function, to develop alternatives to existing policies, to keep them alive and available until the politically impossible becomes the politically inevitable. Thanks very much.